I'm going to hand over at this point to Dr. Funmi. She's with WHO in Geneva, and she will give us some welcome remarks. Over to you, Funmi.
Thank you very much, everybody. I warm to this WHO session on hepatitis B birth dose, and I'm excited to see so many people in the room on a Saturday morning at 8:45. And this morning I thought to myself, why will an HIV audience come for hepatitis B birth dose? So I have a question for all of us. We know so much about lenacapavir. Am I correct? Can I see your hands if we know about lenacapavir? Good. If you know about hepatitis B birth dose, can I see your hands? Wow, this is a fantastic audience. Actually, our work is done. They are convinced. So we welcome you, and we hope to have a very exciting time this morning. We have an outstanding panel. We have a person with lived experience who would share her perils of hepatitis B birth dose for her child. And we have speakers from Malawi, from Nigeria, and from South Africa. And I think we can start now. Okay. Should I begin the presentation?
So thank you very much. I forgot to introduce myself. I'm Dr. Angela Mushavi from the Ministry of Health and Childcare in Zimbabwe, and I'll be chairing. And just as soon as Funmi has finished, she's going to take us through a presentation that really articulates for all of us the critical role of hepatitis B birth dose vaccination in preventing vertical transmission of HIV. So over to you, Funmi, as soon as your presentation is ready.
Okay, so we'll jump quickly into it, and our title is Accelerating Birth Dose Vaccination in Africa. Next slide, please. Next slide, please. Okay, so actually we are talking about triple elimination, and this is the Triple Elimination Initiative, and it's prevention of mother-to-child transmission of HIV, syphilis, and in bold red is hepatitis B. Of course, we know the reasons for triple elimination. We have evidence that it is effective, that it is an opportunity for integration, for person-centered care, and then opportunity to reach people where they are, in general populations, in key populations. Next slide, please. So where is the hepatitis B in triple elimination? This is where it is. 254 million people worldwide are chronic carriers of hepatitis B. That is 8 times the HIV epidemic. So it's pretty significant. There are more than 3,000 new cases globally every day, and there are more than 3,000 deaths every single day from liver cancer and liver cirrhosis. These were the statistics of HIV many years ago, but a lot of advances have been done in HIV. And just to note that the epicenter of the hepatitis B epidemic is in Africa and is second only to China as this epidemic. Next slide, please. So why should hepatitis B be a priority in Africa? This graph sort of shows it all. You would see in the top line in red that the prevalence of hepatitis B in Africa is more than 6% in the general populations. In some countries, it is 10%, which is 1 in 10 people, a very, very frequent epidemic. Next slide, please, the next few slides. So the burden in Africa is more than 65 million. Africa has the highest incidence of new infections. It has the greatest gaps in prevention. It has rising liver cirrhosis and liver cancer. And there are over 4 million children with hepatitis B, most of which are in the African region. Next slide. So, because most chronic infections are acquired through mother-to-child transmission and through early childhood infection, WHO recommends 3 key things. The first and one of the most important is universal timely hepatitis B burst dose vaccination. And I've written in bold blue that all infants should receive this birth dose vaccine as possible after birth, preferably within 24 hours. It's a tall call. The hepatitis B burst dose should be followed by the childhood series, 2 to 3 of those additional doses, which are usually in combination vaccination, heptavalent, pentavalent vaccination to complete that series. And reporting and monitoring of burst dose are important. These recommendations are 2009, so they've been around for a very, very long time. But more recently, and to support that burst dose, we have the hepatitis B surface antigen testing in pregnant women and adolescent girls, as well as antiviral prophylaxis among pregnant women and adolescent girls. These 3 really make up the implementation steps for a comprehensive triple elimination hepatitis B within the mother-to-child transmission. Next slide, please. So, what are these vaccines? The vaccines are effective, they're over 40 years old, they are safe, they provide lifelong immunity, and it's the first anti-cancer vaccine. So how is it that we have an anti-cancer vaccine that we are not fully optimizing? It is most effective within 24 hours. It's given as a deep IM injection. I guess that must be part of the challenges of implementation, and it requires a cold chain. It's freeze sensitive, but is heat stable. Next slide, please. So, birth dose vaccination is the foundation of hepatitis B PMTCT. And we do know that the triple elimination criteria for WHO for hepatitis B requires 90% coverage of birth dose, 90% coverage of 3 infant doses, 90% coverage of testing, and 90% coverage of maternal prophylaxis in different combinations. Next slide. As of 2024, 115 out of 194 WHO member states recommend a universal hepatitis B burst dose for all newborn. That is huge, and most countries do it. So you see in yellow, the countries that don't really have universal birth dose, they're in Africa. So it's a paradox that the areas with the highest prevalence have the lowest coverage. Now, just to note that 33 countries have what we call selective burst dose. They target exposed infants. Yesterday, the USA left this 115, and they may become 114 because the new administration has some health-related beliefs, and they think vaccination may be a challenge. All right, so there are many issues here, but for us in Africa, we really must remain on course to change the trajectory for our people. Next slide, please. So 17 African countries have introduced hepatitis B burst dose, but what I want to show on this graph is less than 4 countries have reached the target of 90% for either the childhood series or for the burst dose, and you can see that on this slide. Next slide. With the support of GAVI, things are changing. In terms of considerations, what are the challenges in Africa? We would hear more from our panelists today, but some things that have been highlighted from several studies are awareness and advocacy. Many people do not even know about the importance or the need for a burst dose. The cost of vaccine is $0.2. That's 20 cents. It's a very cheap vaccine. I know that HPV vaccine is more than $8. Yet there's a huge uptake of the expensive vaccine, but not of the cheaper vaccine. And part of the challenges are with the implementation and with the health systems. Our panel will help us to walk through what these challenges are. There are also challenges of timing. 24 hours is tough. It's a tough timeline for many African countries, especially where children are born out of birth facilities. It's a challenge enough in health facilities, and we'll hear more about that. But the bottom line is hepatitis B burst dose cannot be EPI alone. We need MCH, maternal child health, to support the implementation of this hepatitis B birth dose, and it must be included and recognized within the triple elimination initiative. Next slide, please. And did you know that it's only in Africa that many people pay for hepatitis B vaccinations? And this graph sort of shows it. It's not only in Africa, but it's highest in the Africa region. Next slide. Next slide, please. And there are global opportunities which we need to take advantage of. Global Fund Program provides essential support for scaling up the hepatitis response through for example, the GC7 fund. Over 60 million was approved for triple elimination, and this was to procure testing kits. So there is hope. We also know that GAVI funding has commenced. 12 countries have already applied. Last week, Uganda started their universal hepatitis B birth dose, and that is a real plus for Africa. Multi-country projects and implementations are ongoing, including the United Path Grant, and we need innovations in service delivery, innovations in hepatitis B formulation so that they can go out into the field. We need new diagnostics, new tests, digital technologies for monitoring and evaluation of hepatitis B programs. And last slide. And you know Namibia. Namibia is the superstar. They have achieved WHO certification of EMTCT of hepatitis B, bronze. I think it's the other way around. I think hepatitis B is silver and HIV is bronze. So we laud Namibia because this was built on their solid system of hepatitis B birth dose vaccination. Next slide. And last slide. Some final reflections. Takeaway messages. Timely hepatitis B birth dose is the foundation of hepatitis B EMTCT and, of course, triple elimination. The programmatic considerations are key. Partner support is increasing, including from GAVI, and, of course, government ownership and community engagement are key. I want to thank you all for your time. Thank you.
Thank you very much, Funmi, for that spirited presentation. I'm sure in as much as you have heard about lenacapavir, we are all going to be champions for the hepatitis B birth dose. Thank you so much for that presentation. And of course, we have a brilliant panel this morning. I think you've been told we have community voices, and I wish to welcome you. Anita, how are you? Welcome. Anita is here. She's from Ghana. She has a very beautiful story to tell, which also, in a way, actually emphasizes some of the challenges that you brought out in your presentation. So, Anita, please go ahead and share your story.
Good morning. My name is Anita, and I work with the Hepatitis Foundation of Ghana, and I'm here to share my story. In 2013, I was diagnosed with hepatitis B, and as confused as I was, I started researching on the internet, and I came across the Hepatitis Foundation of Ghana, and together we are creating more awareness about hepatitis B in Ghana. Fast forward, in 2013, I got pregnant with my first child, and a midwife told me to seek herbal medication. But with the help that I got from Hepatitis Foundation, I got to know how to take care of myself through pregnancy. And then I got discriminated by my friends and then my work colleagues. They wouldn't even want to share a cup with me because I was hepatitis B positive. It wasn't easy at first, but with time, I got over it. Fast forward, when I got pregnant, I was offered immunoglobulin right after birth, but it was very expensive. It was around 600 cedis, and I couldn't afford it then. So later, I was given the Hep BD, which costs about 20 cedis, and I was told that it wouldn't give my child food protection, but now I know better. So the reason I'm here today is to create awareness about the 24-hour hepatitis birth dose. A lot of women are going through it, and because they can't afford it, they actually leave their child to grow with hepatitis, and in the end, they might face the stigma that I faced. So I want to plead with the government to make the 24-hour Hep BD affordable, free for every child in Ghana. Together, we can help eliminate hepatitis B and prevent children from getting hepatitis. Thank you. Okay, so the good news is that even though I took the 20 cedis vaccine, my 2 children are not positive with hepatitis.
Thank you so much for that wonderful story. I think, Funmi, you mentioned the issue on out-of-pocket expenses. Some things that we take for granted are really not that easy. And thank you. I'm so happy that the children are okay. We have contributions from the Ministry of Health of Malawi. We are going to have Mr. Joe Konjera share experiences from the Ministry of Health of Malawi on how they are dealing with testing and treatment of women for prevention of hepatitis B to their infants. Thank you.
Good morning, colleagues. Yeah, so as lightly mentioned, my name is John Konjera from Malawi. I work in the HIV directorate within the ministry. The directorate looks at all the 3 diseases, HIV, viral hepatitis, and STI. Just to mention that for viral hepatitis in Malawi, we integrated it into the national program in 2017 because we looked at already a robust HIV program, and having viral hepatitis to ride on the already established HIV program was going to make the implementation very easy. Yeah, so in terms of the ANC, for Malawi, all women that are coming in the ANC, we offer the 3 tests, including HIV, viral hepatitis, and syphilis. What we did was firstly to integrate the viral hepatitis testing into the overall testing algorithm so that when the providers are offering the tests, they are already providing, they're already offering for all the 3 diseases. And that has helped us to easily roll out the testing. And we use ScanForm technology, which is a digital tool. It's an innovation that we use. So it basically captures the summaries of the data from the register and transmits to the national level program. So we are easily monitoring the data in real time. And since the rollout, we've now managed to test, we normally manage to test over 98% of all the women that are coming in the NC for viral hepatitis. Also to share with you that Malawi is working on the triple elimination, pathway elimination for the elimination of the vertical transmission. And we've developed the roadmap, which is also costed, looking at how do we mobilize the resources to manage to achieve by 2030. One of the drawbacks, of course, is the fact that for viral hepatitis, we do not have the birth dose yet. So that means we are still waiting for the support. We initiated the process with our EPI program within the ministry. So we made an application to GAVI so that we can probably have the support of the doses by next year. We believe that that will strengthen will help us to achieve the triple elimination. But in the meantime, what we do is that for all the women that test positive, we are putting them on the universal prophylaxis. So for the women that have only tested the positive for viral hepatitis, those ones we are putting them on TDF 3TC. But for those that tested for positive, positive for HIV as well as for viral hepatitis, we're putting them on the TDF-based regimen, which normally contains 3 drugs. Yeah, so what we are doing now is to make sure that we reach out to more providers because the challenge has been that since we developed the guidelines for treatment of viral hepatitis, we did not manage to train more so that they're able to understand how they can approach a woman and treat. Yeah, so basically, those are the key things that I would want to share with you on how we are implementing the viral hepatitis in ANC. Thank you.
Thank you very much, Malawi. Thank you very much for the presentation. We have an experience sharing from Nigeria. Since we are talking of the birth dose vaccination, we can hear your story. Thank you.
Thank you very much. Good morning, everyone. And thank you to my colleagues. Thank you, Dr. Leslie, for the presentation. And I was glad when I saw that Nigeria was one of the countries that had the birth dose vaccine. And I'm here to share our experience. Despite the fact that we were one of the first countries that commenced birth dose vaccine as early as 2004, as a part of the national immunization program, we still have challenges being able to achieve the targets at 90%, as Dr. Leslie had presented, and looking through to see what are the challenges with this. We know to be able to have effective vaccination, you need the policy to support this, which we have in place as a country. We need the availability of the commodities, which we also have in country, the infrastructure to support that, as well as the workforce, the capacity of the healthcare workers. However, despite this, we still see that we still have suboptimal coverage of a birth dose vaccine. And looking at part of the factors that have contributed to this is we have identified factors related to antenatal and PMTCT as the contributory factors, like the suboptimal ANC coverage, where in country we have some of our women still have preference to delivering outside the health facility, from receiving care and also delivering outside the health facility. And like we have all attested to, the birth dose vaccine, it has been guided that it should be given within 24 hours. And so when you don't even deliver within a health facility, how do you receive the vaccine? So these are strong contributory factors. Beyond that, the awareness is also very key. And thanks for sharing your story. It's also part of the factors where even the mother herself is not even aware of being to receive the vaccine. And one of the places where you receive information, of course, apart from conventional information, there is during antenatal care, where your nurse, gives you information on what you're supposed to receive, how you should take care of yourself. And when you don't even access ANC, how do you get the right information? Talk less of delivering within the health facilities. It has been poverty and the level of social class and education has been one of the factors that have been associated with the coverage of birth dose vaccine in country, as well as a place of delivery. So in as much as we have it suboptimal, but we still have a very wide range of variation across the subnational, where we have some subnationals have extremely low, and we have factors, and those locations also have a very poor facility delivery as well. In country. And of course, the infrastructure is also part of the contributory factors, where you need the cold chain, and you know that it's not available everywhere. So when you have a woman deliver in a facility where you don't have the storage of the vaccine, and she may not have access immediately within 24 hours of sometimes very quick discharge from the facility. And so for her to go and come back, you know that you've already have missed opportunity of, delivering to her. But like Dr. Lexi had mentioned, the three combination that we're talking about is the hepatitis B surface antigen during antenatal, of course, early antiviral, and the birth dose. And so one of one of the interventions that we're deploying for the first time in country, which we had been working on over a period of time, is to now establish the triple elimination initiative in country, where beyond making availability of the three testing, we're also leaving the comfort of a health facility. to get these women tested, irrespective of where they find themselves. I use this opportunity to thank Dr. Akudo. I think that was one of the initiatives she started before she left us, where we'll say, irrespective of where the woman is, if she's on the tree, we go after her and ensure she gets tested. Please, can we clap for her, please? Thank you very much, Ma. And so we started that we're leaving the comfort of the health facility. We go after the women, irrespective of where they find themselves, and not just offer HIV, we're offering HIV, syphilis, and hepatitis. And if you're positive, we're linking you back to the health facility. And this over time has actually improved, and we're hoping if we consolidate this. And like you rightly said, Dr. Leslie, under the GC7 grant, we're one of the lucky countries that got the support from the Global Fund. And we're sure if we scale this up over a period of time, we're hoping this will change. But it's very important. I can't end this without saying, if we do not address the factors that relate to PMTCT, optimizing birth dose vaccine may be a bit difficult. Thank you very much.
Thank you very much for sharing your experiences from Nigeria. I know that we will have questions and comments. Please, at this point, take down your notes, your questions and your comments. We'll have time to have a question and answer session once we've heard from all of our speakers. We are hearing next from Tato Nelly. She's with the WHO country office in South Africa, and she's going to share with us some of the experiences she has had from the side of the WHO supporting the National Department of Health for South Africa. Over to you, Tato.
Thank you very much, Doctor, and good morning, everyone. Let me say all protocol observed, as we say in South Africa. And thank you to the panelists as well. So, a lot of what I'm going to mention, maybe a little bit more detail, has already been mentioned by previous speakers. I don't know if that's the advantage or disadvantage of talking last. So, as mentioned, the World Health Organization aims to eliminate hepatitis B as a public health threat by 2030. And I will limit to the coverage target of 90% among the other targets that our first speaker spoke about. And also, she also spoke about the fact that WHO recommends universal birth dose within 24 hours. And I'll talk to the challenges of that as I go further. But it is important to mention, again, as you saw in the, again, Dr. Fumi's presentation, that coverage regionally in terms of universal birth dose is relatively low, and with disparities across the regions. So having been supported South Africa in this couple of years, while I'm not necessarily talking on behalf of MOH right now, but I think it's important to mention that as one of our speakers, I think it's yourself, the lived experience, talked about the expenses, out-of-pocket expenses in terms of getting or accessing the vaccine. In South Africa, vaccination is free in all public health facilities. Obviously, when you go to private sector, it's a different discussion. But in all our 4,000 public health facilities, vaccination is free, including hepatitis B. Maybe this is good to mention because we have countries, and maybe as we go, especially in this era that we're in of financial landscape, it may be important that as we prioritize and reprioritize, and as governments discuss, there was a lot of discussions about, even in the conference, about sustainability and about finances. So domestic funding, it comes up very important in terms of this. So when we talk about the challenges of accessing the birth dose within 24 hours, I will actually talk to a few key barriers. And again, maybe also, it may or may not have been mentioned, but I think because South Africa was also on the map, we are implementing targeted birth dose. And South Africa has adopted the WHO targets and has the guidelines in place and being revised accordingly. And also there are discussions going on in terms of increasing access and coverage. So the key barriers that I'll talk to include, but are not necessarily exhaustive in this case of my list, but limited awareness and knowledge, literacy in particular. Many pregnant women may not necessarily, and this is now globally, may not necessarily have all what they need to have in terms of capacity building, in terms of the importance of timely birth dose vaccination, and this goes to the communities as well. And this is where our civil society organizations come in, community-led interventions and monitoring to ensure that the recipients of care in this particular case actually understand the importance of birth dose vaccination. Another challenge is accessibility. Even in places where there's availability, if one cannot access, that becomes a challenge. But one usually tends to speak to both accessibility and availability, ensuring that we talk about strengthened supply chain mechanisms, cold chain mechanisms as needed, and to just make sure that we avoid stock outs and ensure that, especially in rural areas, that there is availability. One of the challenges may also be to fully differentiate this service into communities, considering that we need trained professional nurses to ensure the vaccination actually is done. Should I? Oh, okay. This includes the health systems as well. Health system strengthening is very important here to ensure that there is higher effective or efficacy, or rather, no, effective vaccination programs. I will also talk to cultural and socioeconomic factors, cultural beliefs and socioeconomic factors, poverty, low education levels. They can also hinder or affect I spoke about literacy, so the understanding of how important it is to actually access hepatitis B vaccination at birth within the 24 hours. The other challenge is home births. It was mentioned. I'm sure we can appreciate and acknowledge the possible challenges in this instance where a mother needs to access a facility within 24 hours of giving birth. So this really just talks to, I mentioned that differentiated service delivery may be a challenge, but it is also a solution. So we need to try and ensure that those are some of the strategies that can actually be implemented to ensure that we cover the challenges that I've talked about. Integration is another challenge. The whole of this year, in just about every platform that talks to HIV and TB, hepatitis, STIs, we've been talking about integration in response to the challenges that we've had in this current landscape. So integration is very important, ensuring that we mainstream vaccination. Dr. Fume said not only in EPI. So we need to make sure that we are able to integrate the services and ensure that everyone that needs the service actually is able to access them. Maternal education, very important as well, to ensure that we improve literacy. And then again, as I mentioned, to ensure that we integrate. I think I'll pause here. Thank you very much.
Sure. Thank you very much, Tato, for that presentation. At the back there, we have our last panelist in this session who is online. He is not presenting in the room. So we'll be hearing from Dr. Simba Mabaya. He's with GAVI. I hope he can go live. Are we ready? While the technology is going up, we would, defer to you now.
I'm not sure if Dr. Simba is online, but he has given me a list of the 12 countries that are going to be supported from the new GAVI grant, including Eritrea, Ethiopia, Sudan, Uganda, Congo Republic, Rwanda, Ghana, we thank God for that, Ghana, Guinea-Bissau, Lesotho, Liberia, Mozambique, and Sierra Leone. All of these applied in 2025, and we're hoping that more countries will apply in the coming year. So if he can speak, all well, but otherwise, these are the list of countries from GAVI that have applied. Thank you.
Yeah, thank you very much, Funmi. I'm just hearing at the back that we seem to be having some connectivity issues. One moment is on, and then one moment is off. Shall we assume that he won't be able to come on live? Try.
Have a universal burst dose of all the newborns. And the coverage rate is somewhere between 50%. And that is universal. We've heard from South Africa, very interesting, that they have a targeted birth dose. So they don't give it to all infants. They must test the mother first. And positive mothers, their babies are immunized. And there's a huge challenge with that. That means you have to test 90% of positive mothers to find the few exposed to vaccinate. So there's a huge gap there, and many exposed babies will not be identified. We've looked at Malawi that is using a different strategy. They're doing antenatal prophylaxis and treatment and testing. And they're hoping to scale up to burst dose, which will be essential for WHO's path to elimination. So different aspects there. I'm sure there are lots of questions. Is Simba able to talk? Okay. I hand over to you, Simba.
Thanks. Can you hear me?
Yes, we hear you. We can hear you. Please go on. Thank you. We've had a fantastic panel, and I imagine that there are lots of questions. We have somebody with a lived experience. We have in the audience people who may also have had challenges in their personal stories. So we are open to comments, to some of your considerations, to other country experiences, if there are any questions. Thank you very much. Can you tell us who you are, where you're from, and then give us the question? The lady there. Okay.
Good morning. My name is Belani Moa. I'm from Malawi. Yes. Firstly, let me just appreciate the presenters, the panel for the information that has been shared. And I'm so happy to see that Malawi is represented. I work for Compassion International, which is an organization focused on holistic child development. And so we are very passionate about ensuring that children grow in ways that are going to support them to contribute to the development of the country one day. We partner with churches, and these churches are also there to support the various communities to promote the health of their children. Now, I was interested in the birth dose for Malawi. Of course, I see that we have not yet achieved that, but I just wanted to encourage you to say that since the process has already started, it could be good that maybe if it could even be expedited, I don't know, whatever means you can use, but then would appreciate if that could be expedited, one, and would also love as Compassion International to even support in creating awareness of the birth dose, because we are supporting children that are from the age of 0 to around 18-22. So once that is in place, Compassion International would support in creating awareness in the districts where we are working. Currently, we're working in about 12 districts. So I just wanted to share that as an encouragement to the representative from Malawi, and also for him to know that there are other organizations that are interested and will even support in creating awareness. Thank you.
Thank you very much for that contribution, and I'm so happy that Malawi is here. And just to note that Malawi is doing a great job. in terms of testing and maternal prophylaxis. So thank you very much. There's also a question from that head. Mike? There he is on that. I think you have a mic in front of you though. Is it working?
No, please.
Oh, it's not working. Thank you. Can you make the question brief or the comment brief? We have 7.
Good morning to the panelists and the presenter. It was great. My name is Dr. Zubon. I'm from Nigeria. I work for Clinton Health Access Initiative. My question is concerning looking at Nigeria now, and in the field, you find out that most of the communities are farming communities where they leave their houses to their farms and may stay for months, and they will not come back. Maybe during harvesting season, they will not harvest and come back, and we are trying to encourage bed dose. So my question is, what happened to such women? Because they leave, and their children, they leave straight to the farm that is different from their communities where they stay, and no facilities there. When they come back, how do we cover for this bed dose? That's my question. Thank you.
Thank you very much. Can we have the last question? Oh, before we wrap up, I'm told that we are actually running on extra time now. So, one last comment question, and then the panels will have 1 second each. 1 second to make a quick comment.
All right, thank you very much. My name is Washington from Malawi. My question is direct to WHO. I'll diverge a bit. I'll talk about hepatitis C. Yes, but
we take that offline. Today is birthday.
Okay. Yes, so I know that many countries now we are introducing people who use or injected drugs programs, and we all know that the prevalence of hepatitis C amongst this population is high. But in terms of the direct antiviral treatment, are not really available in many countries. What is WHO doing to ensure that we improve access to the treatment of hepatitis C? Thank you.
Thank you very much. We will see you after the session to talk about hepatitis C. But I think the most important thing for this session is that even people who inject drugs, you have females who inject drugs, they get pregnant, they have hepatitis B. So their access to birth dose is what we would probably address in this particular session. So thank you. So you have 1 minute, 1 second each to make a quick statement. We're over time. 1 second. Sure.
Right. One quick statement. We need to integrate to ensure that we streamline it through into public health services, this vaccination, to ensure that we increase coverage. Thank you.
Thank you. Like I had mentioned, we have seen that availability doesn't equate to access. We have the policy, we have the vaccines available, but how about the access? So anything that will encourage access, for instance, the ANC coverage, reaching the women, testing them, the place of delivery, I think if we're able to address that, we can actually address the birth dose vaccine. For the question on that, I think I'll take it offline because of time. Thank you.
All right, thank you so much. So I think for Malawi, we think integration is key, leveraging the already existing platforms to scale up the birth dose, and also looking forward to when we can have the actual birth dose rolled out in Malawi. Thank you.
All right, thank you for this opportunity. I think in Ghana, I would like to plead with the government to make the 24-hour birth dose free for children, so that they wouldn't face stigmatization. Thank you.
Thank you very much. And maybe to address your question, it's a very critical question. 40% of African women deliver outside facilities, and they're a challenge for birth dose. So alternative models of service delivery for these women are key. And one of the research we're looking at is like in Malawi. So the hepatitis B testing and prophylaxis, can it be a strategy to support such women who do not have access to 24-hour birth dose? We will have the answer in a few months. So bridging that gap for those hard-to-reach facilities also include modifications of the birth dose out of cold chain use and various modifications. They're even trying patch patch approach for hepatitis B birth dosing out of facility is still a challenge. There's a UNITAID study going on. It's going to look at that as well. So on behalf of WHO and all of us, I want us to give our panel a round of applause. They've been amazing. And I thank very much. I'll give it to you.
Allow me to thank the presenter as well, Funmi, passionate presenter.
Thank you. And I want to thank our advocate. She was very shy to come. And I told her that in HIV sector, the activists are not shy. Did I not tell you that? So we need hepatitis voices to come out. You rarely see hepatitis voices. We need more of you. We need you to mobilize the community. We need the women to demand. Please let us learn from our HIV activities. Thank you so very much. Thank you all. Thank you.